Hello, my name is Dan Claw. I am a rheumatologist who is a professor of anesthesiology at the University of Michigan, and I'm going to talk today about diagnosing and treating chronic pain based on the underlying mechanism. I always start my talks with this slide that shows two different individuals' knee x-rays, the normal knee x-ray on the left and grade 4 osteoarthritis on the right, and I pose the question at the top, which person has pain? Because it wasn't until the mid-1990s or so that we didn't actually know that we couldn't accurately predict who would have pain based on just looking at a radiograph or a CT or an MRI. But it turns out it's not surprising that about 10% of people with severe knee pain will have a normal knee x-ray. But what is surprising, I think, to most individuals is that 30 or 40% of people with this knee x-ray don't have any pain whatsoever. So why is it the case that whether you're using plain X-ray or CAT scan or MRI, excuse me, there's a significant disparity between what you see on imaging and whether someone is experiencing pain and how severe that pain is going to be. And so I'm just going through my career and the way that osteoarthritis has changed. When I was first trained in the late 80s, we thought that osteoarthritis was the classic peripheral pain syndrome, and that it would be the case that whatever you saw in an x-ray that people should be feeling. But it wasn't. Again, then in the 90s, those studies began to come out showing that there was really a terrible relationship between what you saw in an x-ray and whether someone had pain or not. When researchers saw that a lot of individuals were having pain that wasn't there on an x-ray, they looked to see if psychological factors could be explaining this variance between what you see in an x-ray and what you see with respect to pain. And although psychological factors are important in pain, they don't really explain this variance. And one of the things I like pointing out is that some of the therapies that I was taught were really effective to treat chronic pain. Subsequently, we know that they're not very effective. Classes of drugs like nonsteroidal anti-inflammatory drugs and acetaminophen, they're helpful in people with conditions like osteoarthritis, but they probably don't work in any more than about 1 out of 3 individuals. Opioids, now the latest Cochrane meta-analyses strongly recommend against using opioids to treat osteoarthritis. And even joint replacement surgery, there's 20 or 30% of people that have their hip or their knee replaced that don't have improvements in pain. And we and others have used those surgical techniques and research involving pain relief to make inferences about different mechanisms of pain that may respond to different types of treatment. The condition fibromyalgia has gone through quite a metamorphosis over that same period of time. This used to be called fibrositis until about the late 80s, where the rheumatologists realized there was no itis, there was no inflammation in these individuals with fibromyalgia, and it could be easily distinguished from autoimmune diseases where there was inflammation. But the original criteria for fibromyalgia that were published required widespread pain plus a certain number of tender points, these 18 areas of the body where you push with about 9 pounds of pressure, and if someone said they hurt, that was considered a tender point. That was good in that it got at hyperalgesia allodynia, that fibromyalgia might be a disorder in central pain processing. But what was bad about those criteria is that we didn't know that women are a lot more tender than men. And so if you require that a certain number of tender points is present before diagnosing fibromyalgia, you make fibromyalgia out to be an exclusively female disease. And I would contend that one of the reasons it was easy to be dismissive of conditions like fibromyalgia is that a lot of male providers could sort of, in a pejorative way, say, well, this just occurs in neurotic middle-aged women, and really be dismissive of conditions like fibromyalgia and other pain syndromes that we refer to as nociplastic pain. Now, 30 or 40 years later, it's gratifying in that the International Group of Pain Researchers formally voted a few years ago to say that there was a third mechanism of pain called nociplastic pain. It used to be called central sensitization, where the central nervous system seems to be driving the pain. We know that the whole person is tender. It doesn't really matter where you push. People with this kind of pain will often be tender throughout their entire body. And they're not just more sensitive to painful stimuli. If you push in different regions of the body, they're more sensitive to the brightness of light, the loudness of noises, odors, and it really is any type of sensory stimuli seems to be encoded in the brain as being more intense in people with this kind of pain. And that's helped us localize some of the brain regions that are most abnormal in conditions like fibromyalgia are brain regions like the insula that are involved in the polysensory integration of sensory information in the brain. And so one of the analogies I've been using for about 20 years now is that the amount of pain that someone experiences is akin to the loudness of an electric guitar. And there's two ways you can make an electric guitar louder. You can either strum the strings harder or you can turn up the amplifier. And the strings are the equivalent of the sensory nerves that we have going to any region of the body. In this case, I'm just going to show you those two knees that I showed earlier. But we have some nerves that pick up heat and cold, some nerves that pick up pressure, some nerves that pick up where you are in space. And all of these different nerves, the information from these nerves has to go up through the spinal cord and up to the brain to help localize the pain, to help feel how intense the pain is. And the entirety of the central nervous system, the brain and the spinal cord, have a tremendous influence on which of this information from the periphery is allowed to go up to the brain to be felt as pain and which is filtered out. And so the study of conditions like fibromyalgia, where we think that the primary problem in fibromyalgia is an amplifier problem, people have too high of an amplifier setting, it doesn't just help us explain why someone with fibromyalgia might have pain in spite of this normal knee x-ray. It also helps us explain why so many individuals that have this knee x-ray don't have pain. It isn't surprising, given what we know now, that most of the people in the US population that have this knee x-ray on the right and don't have pain are men. And the reason for that is that on average, men are less pain sensitive in the central nervous system. Men have about, I'm sorry, let me turn this around. Women have about 1.5 or 2 times greater rates of almost any type of chronic pain. And this seems to be either solely or largely due to the fact that women have a higher amplifier setting. If it wasn't annoying enough to be a female in this regard, if a woman is actively menstruating, she'll often become more pain sensitive and more sensory sensitive in the premenstrual phase of her cycle. And so we see that there are hormonal influences on pain sensitivity, and that because of this, males seem to be less pain sensitive than females. And until 5 or 10 years ago, there were only 2 columns here: nociceptive pain, which is pain due to inflammation or damage, or neuropathic or nerve pain. And now we have this third category that used to be called centralized pain. Central sensitization is now referred to as nociplastic pain. And we think this is primarily a central nervous system driven problem. And we know how to identify these individuals. The pain will be much more widespread. If you give someone a body map, which I would highly recommend, that any patient you see with chronic pain, you give them a body map and you see all the different regions they're having pain in, the more widespread that pain is, the more likely this is an amplifier problem rather than just strumming one string in the guitar too hard. And the other thing that can clue you into the fact that this is nociplastic pain coming from the brain rather than nociceptive pain coming from the knee is that people have some of these other symptoms that come from the central nervous system: fatigue, sleep problems, memory problems, mood problems, and they are sensitive to other type of sensory stimuli, such as the brightness of lights, the loudness of noises, odors. And so when you see those features, widespread pain accompanied by fatigue, sleep, memory problems, accompanied by sensory sensitivity to other types of sensory stimuli, that should be a blinking neon light to you as a clinician that this individual has a different type of pain that needs a different type of treatment, because surgery, injections, opioids, nonsteroidals are not going to work in this kind of pain. They're going to work if someone's pain is coming from the periphery, but they're not going to work in pain that's coming from the central nervous system. And instead, you're going to have to use CNS acting non-opioid drugs, as well as the aggressive use of non-pharmacologic therapies. And so our classic nociplastic pain syndromes, these are also called primary pain syndromes, and the new ICD-10 classification criteria would include fibromyalgia, functional GI disorders like irritable bowel, temporomandibular disorder, tension headache, interstitial cystitis / bladder pain syndrome. These are all now considered primary pain syndromes because the primary problem is the pain. The pain isn't secondary to osteoarthritis or autoimmune disease or cancer. Another point of emphasis is that it's very common for individuals to have more than one mechanism of pain. About 30% of individuals with osteoarthritis or autoimmune disorders or cancer pain, in addition to having nociceptive pain, also have nociplastic pain. And if they have this mechanism of pain and this mechanism of pain, you need to treat both. And the same holds true for neuropathic pain. So you have to really look at every individual and see what mechanism of pain they have and treat based on the underlying mechanism of pain. So you're going to see more and more review articles using this term nociplastic pain. This is one of the first that came out in Lancet. And again, we know that the fundamental problem in these conditions is augmented central nervous system pain processing, but also sensory processing. Again, bright lights, loud noises, odors. And these individuals have a lot of side effects of drugs that are not allergies, they're hypersensitivities. And we see that in addition to these sort of pain and sensory hypersensitivity problems, that these individuals have other CNS symptoms like fatigue, sleep problems, memory, and mood problems. Another term that's being used more is chronic overlapping pain conditions. The classic chronic overlapping pain conditions are conditions like headache, fibromyalgia, irritable bowel, TMD, interstitial cystitis, low back pain, endometriosis, vulvodynia, and chronic fatigue syndrome. These all are more like, if someone has one of these conditions, they're more likely to have many of these conditions. These conditions run in families. And note that some of the individuals with these conditions, like chronic fatigue syndrome, they don't have as much pain, but they have all the other cardinal symptoms, the memory problems, the fatigue, the sleep problems. And we see this, for example, in some of the post-infectious nociplastic syndromes that are triggered, for example, by COVID or so-called long COVID, is now really thought to be almost identical to chronic fatigue / fibromyalgia. But many individuals don't have prominent pain. They have all the other symptoms, not the pain. And again, nociplastic pain might be front and center in these conditions, these chronic overlapping pain conditions or primary pain conditions. But we know these same nociplastic mechanisms are very prominent in conditions like rheumatoid arthritis, lupus, sickle cell disease, cancer, that might start out as nociceptive pain, but over time, that as individuals have had the pain longer and longer, they develop central sensitization and more nociplastic pain. These are the current criteria that are used to diagnose fibromyalgia. Our group thinks that these are really nice criteria to use to look at the extent to which someone has nociplastic pain, because they look both at how widespread the pain is on a body map in the left, and then they ask people about these symptoms like fatigue, memory problems, and sleep disturbances. The body map is just summed from 0 to 19, depending on how many sites people check. These are scored 0, 1, 2, or 3, depending on how severe they are. And then people get 1 point each for irritable bowel, depression, or headache. But the total score for these fibromyalgia criteria can be as high as 31. If someone has a score of 13 or greater, they are said to meet criteria for fibromyalgia. But a point of emphasis is you really shouldn't think of fibromyalgia or nociplastic pain as either being present or absent. That Fred Wolf used the term, which I'm not necessarily recommending you use this term, but he coined the term fibromyalgia-ness to say that different people had different degrees of this. And our cut points for saying someone either has versus doesn't have fibromyalgia are totally arbitrary. And instead, we think it's helpful to use something like the fibromyalgia measure to put people on a continuum and say this individual has a very low fibromyalgia score, so their pain is probably entirely nociceptive and neuropathic and should be treated as such, whereas this person with intermediate or high score may have some nociceptive or neuropathic pain, but in addition to that, they also have nociplastic pain, comorbid fibromyalgia that needs to be treated with a different set of treatments. And so just to give you an example of this, if someone comes into you with knee pain and you don't give them a body map, you might think that they have a problem confined to their knee, but if you had them fill out a body map, you'd see that this would be a classic fibromyalgia patient. And it's surprising how often this happens. If you don't use a body map, there's a tendency for us clinically to focus on the region of pain that someone comes in with and not see all this pain elsewhere in the body that would pretty clearly cue you into the fact that if you give an injection to this person's knee or you replace their knee, it's not likely to work as well as if the knee was the only site of pain this individual was experiencing. And so a lot of times you don't know that someone has this kind of pain or fibromyalgia, and it's sort of like a iceberg. There's very large numbers of individuals that don't carry the label of fibromyalgia or nociplastic pain, but they have this kind of pain and it's being inappropriately treated, or it's not being recognized or treated at all. And these people get way too many surgical procedures, way too many injections, way too much opioid treatment, because these treatments are not going to work for these individuals whose pain is coming from the central nervous system. Again, the old term for this was central sensitization, and we know that regardless of whether someone starts with osteoarthritis or rheumatoid arthritis or sickle cell disease, if they develop central sensitization, if their pain becomes more of a central nervous system driven problem, then it's not going to be responsive to surgery, injections, opioids, these other types of drugs. And this is just a graph showing that people with just pain in one region of the body have sort of a low degree of fibromyalgia, low degree of central sensitization. But then there's other chronic low back pain where in some individuals, it's only central sensitization, and in other individuals, it's a back problem, and in other individuals, it's a nerve problem. And then finally, these chronic overlapping or primary pain conditions where this is the major mechanism. We've used surgery that is meant to treat pain as a way of looking at the nociplastic pain and central sensitization, and we've used the fibromyalgia measure as a surrogate measure of this in studies of individuals with osteoarthritis of their knee and their hip getting surgery to relieve that pain, and women with chronic pelvic pain getting a hysterectomy to relieve their pain. In these studies on the day of surgery, we gave people this fibromyalgia measure, which, as I said earlier, that 19 of the 31 points come from how many points on a body map someone has. The other 12 come from looking at fatigue, memory problems, sleep disturbances, these other symptoms that occur. And then again, looking at this as a continuum rather than that 13 or higher is fibromyalgia. And what we see both in individuals getting their knee or hip replaced or in women getting a hysterectomy for pain control, nearly identical findings, that for each 1 point increase in the fibromyalgia measure, people need more opioids to control their acute pain. Opioids just simply don't work to treat the pain in these individuals. That for each 1 point increase in the fibromyalgia measure, people were 25% less likely to benefit if they had their knee replaced or if they had a hysterectomy. And these phenomena were nearly linear from a score of 0 to a score of 18. And so again, think of the degree of fibromyalgia that someone has rather than thinking of fibromyalgia as yes or no, and realize that this phenomenon is actually much stronger than anxiety, depression, catastrophizing in predicting, for example, who does and who doesn't respond to knee replacement surgery or hysterectomy. This is just a slide from the knee and hip replacement studies. On the bottom is the fibromyalgia score on the x-axis. On the y-axis are the number of people that had that score. And you can see the bright red line that on the right side of this line, people would be said to have fibromyalgia. There were about 55 out of 700 or so people in this study that actually on the day of surgery, we gave them the fibromyalgia measure and we saw they met criteria for fibromyalgia. None of these people had ever been diagnosed with fibromyalgia before. So going back to that iceberg that I was showing you, these people did really poorly when they got their knee or their hip replaced. And no one had ever picked up on the fact that they had something other than just plain old osteoarthritis, that they actually had nociplastic pain or fibromyalgia. But look at two people that don't have a fibromyalgia score that's high enough to be labeled as fibromyalgia, this person here and this person here. This person, in addition to having knee pain, had pain in a couple other sites, had some mild sleep issues, some mild fatigue, And because of that, he got a fibromyalgia score of 11. This person got a fibromyalgia score of 2. But look at how different these people are. This person doesn't have fibromyalgia because they don't have a score of 13. But patient B, compared to patient A, needed 90 milligram more of oral morphine equivalents just in the first 24 to 48 hours to control his pain. And this person is 5 times less likely than this person to get a 50% improvement in their pain if they do have surgery to control their pain. So this isn't a minor difference, a five-fold difference in the likelihood that surgery is going to work. At 90 milligrams more of oral morphine equivalents between this person and this person just in the first 24 to 48 hours. And yet, again, very few surgeons or providers are using anything like this measure to decide who should have surgery, who should get an injection, or in fact, who might be benefiting from an opioid to treat their acute pain. And so when we come back to this table, as I emphasized earlier, we really should not think of that everyone with the label of fibromyalgia only has this kind of pain, because some of them might have some nerve pain and some of them might have some nociceptive pain. And conversely, we know that about a third of individuals with these types of pain also have central sensitization or nociplastic pain. And if you don't recognize that, these individuals are not going to get better. If you give someone a body map or the entirety of the fibromyalgia measure and you see that they score high, that doesn't just tell you what's not going to work, it tells you what does work. So the drug duloxetine was approved in the United States for use in chronic low back pain and in osteoarthritis before we knew what subset of people with chronic low back pain and osteoarthritis it would work best in. It's the people with more widespread pain. So if someone just has chronic low back pain in one site of pain, duloxetine is not nearly as likely to work as if they have 5 or more sites of pain besides the back. The more multifocal the pain, the more likely duloxetine is going to work. And if someone has 5 or more sites of pain, and this is a body map that Chad Brummett in our group developed, the Michigan body map, then the individuals with 5 or more sites of pain are 60% more likely to respond to duloxetine than people with just pain at a single site. And similarly, in osteoarthritis, the same thing's been shown. So by just using a body map or by using the fibromyalgia measure, we can see that why some individuals are not going to respond to things like surgery or injections. How do we know that this is coming from the central nervous system? Well, our group and others have done a lot of different studies. This is the first functional MRI study done in fibromyalgia. It was done by our group a long time ago, led by Rick Gracely. And all the study really showed is that when fibromyalgia patients say they hurt when they go get a low intensity stimulus to their thumbnail, they really are hurting. We could see that when we gave fibromyalgia patients a really low amount of stimulus intensity, they said they were getting a lot of pain. And we could see that even though we were pressing with really light pressure, they were getting activations in the primary and secondary somatosensory cortices, which are brain regions we know that are involved in the localization of pain and the coding for the intensity of pain. So all this study really did, this first fMRI study did, was show us that fibromyalgia patients were lying. They really were more pain sensitive. Subsequent to this, we and others have replicated those findings scores of times and now use techniques like functional connectivity. And this is predictably abnormal in people with nociplastic pain conditions like fibromyalgia. And there's specific types of hyperconnectivity between different networks in the brain, like the default mode network that's normally supposed to be active when you're resting, but is more active in these nociplastic pain states. And it seems to be enmeshed with other networks like the somatosensory networks in people that have these nociplastic pain conditions. And the size and the shape of the brain even changes, especially in these nociplastic pain conditions, probably due to neuroplasticity, that the brain and the nervous system are constantly remodeling. And by the way, our group and many others think that this is also what causes so-called small fiber neuropathy. I don't think there's actually any such thing as small fiber neuropathy. I think that that's due to neuroplasticity from the central nervous system. And we certainly do know now that there's at least 200 or 300 medical conditions where small fiber neuropathy has been identified. It's a very nonspecific finding, and I think people have to be very careful about jumping on that bandwagon as far as doing the biopsy and trying to infer anything at all from someone having a quote unquote positive biopsy for the skin findings of small fiber neuropathy. But functional imaging of the brain can, even with really small samples, this is Tor Wager's group by Marina Lopez Sola, showed that using healthy controls in fibromyalgia patients and then machine learning while giving them a number of different sensory stimuli, that you could very predictably tell the fibromyalgia patients from the controls using machine learning, just looking at less than 40 patients, high sensitivity and specificity from these imaging findings. Our group and others have been looking at people with conditions like rheumatoid arthritis or lupus that have comorbid fibromyalgia. This is reviewing a series of studies done by Yvonne Lee, a rheumatologist at Northwestern, that shows that when people have comorbid fibromyalgia or nociplastic pain, they have much higher rates of fatigue, memory problems, and sleep disturbances. You can see this on quantitative sensory testing. And in a small study, Yvonne actually showed that one of the drugs that was approved for use in fibromyalgia seemed to be effective in rheumatoid arthritis patients who had no inflammation, but still had a lot of pain. Again, these 30% or so of people with any autoimmune disease that have prominent nociplastic pain do seem to respond. Again, a drug like duloxetine would have the same effect as milnacipran to treat that kind of pain that's often a comorbidity. These are imaging studies done by Neil Basu at University of Glasgow. This first study shows that in rheumatoid arthritis patients, the higher the fibromyalgia score, the more you see this default mode hyperconductivity, insular hyperconductivity. But in a second study later that year, you see an entirely different conductivity pattern in people with rheumatoid arthritis whose pain seems to be driven by active inflammation. Again, the higher sedimentation rate people have an entirely different conductivity pattern than those people with a higher fibromyalgia score. And so the drugs that do work in this kind of pain are central nervous system non-opioid analgesic like tricyclic drugs, serotonin norepinephrine reuptake inhibitors, and gabapentinoids. And the drugs that don't work are opioids, NSAIDs, corticosteroids, benzodiazepines. And again, we don't think that there's any single drug that's going to work in all people with conditions like fibromyalgia, because there's a number of different neurotransmitters in the central nervous system that can either turn up or turn down the volume control. And there's evidence that there's disturbances in a number of these different neurotransmitter systems. And for example, our group has done imaging studies showing that the drug pregabalin selectively works in the individuals with fibromyalgia that have the highest glutamate concentrations in their insula. And this sort of makes sense, that we know that that's one of the ways in which gabapentinoids and ketamine and memantine, some of these other drugs that are NMDA receptor antagonists, might be working. But drugs like pregabalin didn't work at all in the patients that have normal levels of glutamate in their insula. And it may be that other person with fibromyalgia got fibromyalgia because their GABA was too low, not that their glutamate was too high. And maybe they would have to use drugs like gamma hydroxybutyrate. We even know, I'm not recommending alcohol as a treatment for fibromyalgia or chronic pain, but a low amount of alcohol consumption, alcohol being a GABA agonist, has been shown in several different studies to be sort of protective against nociplastic pain or fibromyalgia. So because there are so many different ways in which you can get to this final common pathway of nociplastic pain, I don't think there's ever going to be a drug that's going to work in everyone with a condition like fibromyalgia. Certainly opioids don't work in these individuals. There's a lot of evidence for this. This particular study was really sobering. This is a study we did where we used both functional MRI and PET with a highly potent opioid, carfentanil. And we concluded from these studies that in the brain regions that were most abnormal on functional MRI, the individuals with fibromyalgia seemed to be having over-release of endogenous opioids, endorphins and enkephalins, which we know are high in the spinal fluid of people with chronic pain conditions like fibromyalgia. Well, what we said is that this looked like endogenous opioid-induced hyperalgesia. We know that if you give rats or humans opioids repeatedly over time, you can get them to become more pain sensitive over time. And this is why we are worried that if people with conditions like fibromyalgia are given an opioid, their pain actually might be made worse over time rather than made better, as many studies are showing now that if you follow people for a year or longer after they're given an opioid for pain, that often you see a statistical increase in their pain intensity over time. Cannabinoids can be somewhat helpful. One of the major benefits of cannabinoids over opioids is that there are no cannabinoid receptors in the brainstem, and so people can't die of a cannabinoid overdose. Like 80 or 90,000 people in the US are dying of opioid overdoses or benzodiazepine or alcohol-related overdoses. All of those other classes of drugs, alcohol, benzodiazepines, and opioids, do depress respiration and do contribute to overdose deaths in the United States. I'm a lot more excited about CBD or cannabidiol use in chronic pain than I am about THC. But if CBD alone does not work in chronic pain, if someone is going to try THC, they should start at a really low dose and go up very slowly, because there's a lot of trials that suggest that a low amount of THC might work better than a high amount of THC. There might be a U-shaped curve. And again, I think this is very analogous to opioids. Opioids, if given for a short period of time in a low amount, they're quite safe and they can be helpful for acute pain. But the longer that someone takes an opioid, the higher the dose, the less likely it's going to help and the more likely it's going to hurt. And I think we see we're seeing the same things, especially with the use of high doses of THC. Just like high doses of opioids, people generally turn into couch potatoes rather than these drugs really being a benefit to them. But we are now getting to the point where if you phenotype people just using a body map or using something more sophisticated like the fibromyalgia measure, and you see that someone has nociceptive pain, then NSAIDs are going to be helpful. Opioids are more likely to work for the acute pain. Surgery and injections are going to work. But if someone has centralized pain or nociplastic pain, you're going to have to use tricyclics, serotonin, norepinephrine, reuptake inhibitors, gabapentinoids, and maybe a little bit of THC. The non-drug therapies can be especially helpful in any type of pain, especially nociplastic pain. And it seems as though that over time, people develop more and more central sensitization and nociplastic pain. The longer they have pain, the more stress they develop, the less active they are, the more they sleep poorly, they gain weight, they develop bad habits. And so non-pharmacologic therapies become particularly effective after people have had pain longer and longer periods of time. And the pharmacologic therapies or the procedures are working up here. The non-pharmacologic therapies are really trying to address the dysfunction that occurs over long periods of time as people have had chronic pain. Many of us think that long COVID is the same as fibromyalgia chronic fatigue syndrome. That's a different talk for a different day. But we know now that a lot of these non-pharmacologic therapies have increased in the evidence base. When I wrote a review article in JAMA in 2014, nearly all of these treatments here for fibromyalgia were down in the weak evidence, but because of all the different studies that have been funded using these non-pharmacologic therapies, the evidence base keeps increasing and increasing. And we now even have 5 different types of cognitive behavioral therapy. We used to just have pain, 8-hour sessions of pain CBT. Now there's brief forms of pain CBT like Empower. There's other forms of cognitive behavioral therapy like acceptance and commitment therapy. And then there's new forms of different cognitive behavioral approaches. One's called pain reprocessing therapy. Another is called emotional awareness and exposure therapy. And these latter therapies with PRT or an emotional awareness therapy really look very promising, especially if we can develop brief versions of these different types of therapy. You can even use cognitive behavioral therapy for insomnia in the individuals with chronic pain that have significant sleep problems. We also think that web-based therapies can be really helpful. This is a early version of FibroGuide that was developed by Dave Williams in our group, where we showed in a trial that this worked probably as well as any of the drugs that are approved for fibromyalgia. We weren't suggesting that it should be used instead of the drugs. We were suggesting it should be used in addition to the drugs. But subsequently, Dave and a number of us have developed Pain Guide. This has now been shown to be effective in a number of different pain conditions. It's now being tested in a number of large NIH trials, but this is freely available to anyone that wants to use it. And we think that these kinds of things can be really helpful in giving people access to these non-drug therapies and a website, allowing people to track their symptoms and see after they try a new treatment what's helping and what's not helping. But again, there's a lot of ongoing therapies with websites, apps that we think can be really helpful. Some controversies in chronic pain. Vitamin D is low in most individuals with chronic pain, but this is probably because they don't get outside as much. It probably is helpful to replace their vitamin D, but the trials have suggested that that usually doesn't lead to improvement in pain. I already said I don't really think small fiber neuropathy is causing fibromyalgia, or for that matter, much in the way of chronic pain, but that's a different talk for a different day. There is inflammation and glial cell activation in nociplastic pain and fibromyalgia, and we're trying to figure out that low-grade inflammation that we see in the conditions like fibromyalgia. Can drugs like glial cell inhibitors work on that? What is the role of that? But it seems to be a different kind of inflammation than we see in autoimmune diseases. And then finally, can things like diet and nutrition be used to treat pain? This is a series of studies that we did in individuals that were taking a very low-calorie diet to lose weight. We followed them for 12 to 16 weeks, and we saw that even though these individuals were not chronic pain patients, that a lot of them had pain, and pain got better, fibromyalgia scores got better, depression got better after these people were in the program for 12 to 16 weeks. When we first published this, we concluded that this weight loss was leading to improvements in all of these things, but then we subsequently published and showed that a lot of this improvement in pain and fibromyalgia scores occurred within 7 to 10 days. So now we don't feel that this is an effective weight loss. We think there's some direct effect of caloric restriction on pain and pain sensitivity, and this might be a promising treatment. What we do know are the promising treatments are these non-pharmacologic therapies. The VA and the DoD treatment centers in the United States are a little bit ahead of the curve in that theoretically all of these therapies are now available to veterans. A number of manual therapies like massage, chiropractic manipulation, acupuncture, again, a number of different types of cognitive behavioral therapies, and then different types of movement or exercise therapies, yoga, Tai Chi, resistance exercise, aerobic exercise, strengthening exercise. All of these can be effective. And our challenge really is making these therapies, which many of us think should be called integrative therapies, all of these therapies used together in an integrative approach, together in individuals with chronic pain. And so the last slide here is that if you're seeing individuals with chronic pain, either give them a body map or the fibromyalgia measure to determine what pain mechanisms are present, because that will help guide your treatment. Look for and treat common comorbidities like sleep problems, mood, and fatigue, because often providers have a better idea how to treat these comorbidities than they do to treat the pain. And certainly sleep, we're learning more and more that poor sleep might be a cause of nociplastic pain. And so getting people sleeping better is a laudable goal. Embrace the effectiveness of non-pharmacologic therapies. If your patient feels that you think that these are the most effective and most important therapies, they'll use them. If you're dismissive of them, they won't use them. Your patients can tell if you think that these are effective or not. And probably the biggest thing that you can do if you're taking care of individuals with chronic pain is encourage people to try some new non-pharmacologic therapies. One of the things that I say to patients is that each of these non-pharmacologic therapies like yoga and acupuncture and Tai Chi and mindfulness and cognitive behavioral therapy works in about 1 out of 3 individuals. And if you, over the next year, try 3 of these non-pharmacologic therapies, odds are one of them is going to help you. And then you retain that therapy, and then the next year you try a couple new therapies, and you retain the ones that are a benefit to you, and you discard the ones that don't work. But the individuals with chronic pain that are doing well usually are doing well because over time they figured out a couple different non-pharmacologic approaches that they can use that make them better, and they use drugs judiciously and more aggressively use these integrative non-pharmacologic approaches. Thank you.